Hello, class, and welcome to our second lecture of Module 2 for our HIM 290 class, Introduction to Medical Coding. In this lecture, we're going to discuss Chapter 3, The Basics of Coding. This is going to be a quicker lecture than the previous one. I'm not going to get into too much detail about each code set because that's what we're going to be discussing in our upcoming modules in the next few weeks. But this is going to give you just kind of a brief overview of what we're going to be discussing, the four code sets, and kind of a little bit of a history of each of these code sets. So that's what we'll be doing in this lecture. This is what you'll be reading about in Chapter 3. Identifying those types of codes. We'll be going over the history of each of these code sets, talking about other things that these codes are used for besides just diagnosis and procedure coding. What we might see coming up, some future coding developments. We'll talk more about that code linkage, medical necessity, and healthcare coding guidelines. Brief discussion of coding guidelines. Again, we'll get into much more detail in upcoming modules. Healthcare codes. Again, what are they? They can be numeric or alphanumeric. It's the translation of everything that's in that medical record. So rather than submitting that record in its entirety to the payer and having the payer read through all of that documentation and they're deciding how this will be reimbursed, all of that data then is translated into those numeric and alphanumeric codes, which then, as we saw in that previous chapter, are added to that claim. That claim form, whether it be the CMS 1500 or the UB04, and that's what would be submitted to the payer for reimbursement. But you have to know how to use these code sets, how to read these code sets, those tabulated listings of healthcare codes. So HIPAA has outlined the use of 5 code sets adopted for use in our electronic medical records and documentation. So when HIPAA when this came to be, when HIPAA, when that was enacted back in it was like what 1996, they talked about how that each of these covered entities, we talked about what a covered entity was, each of these covered entities have to use these code sets, and they identified what code sets are to be used. And the reason why it's so important that they identify this is that there's a national standard. It would be incredibly confusing if one state decided to redefine all of these different diagnoses and procedures using their own code set, or let's say a hospital decided to create their own code set. Now, there's got to be some national regulation and standard. And so HIPAA does outline the use of those 5 code sets adopted. So ICD is one of them, and that's actually divided into 2 subsets. We'll talk about that. Healthcare Common Procedure Coding System, or HCPCS. That's also you've got your HCPCS and then you have your CPT. And I'll talk about that in a second. HCPCS is actually 2 different code sets. You've got your codes on dental procedures, CDT codes, and the NDC. So we're going to be discussing the 4 code sets that are normally used routinely in medical documentation. We're not going to go into dental codes. The American Dental Association owns those dental codes. We're not going to be discussing those in class. Also, we're not going to be discussing the national drug codes, those NDCs. What those are is those are a unique 10 or 11 digit 3-segment number, and what that number identifies, that drug code, it identifies the labeler or the manufacturer of that drug, the product itself, the drug, and the commercial package size. So drug establishments such as like pharmaceutical companies are required to provide the FDA with a current list of all the drugs that are manufactured, prepared, propagated, compounded, or processed for sale in the United States. And the FDA publishes those listed numbers, those NDCs, in a directory which they update daily. So again, we're going to be discussing three of these code sets used within healthcare coding. So we'll go over the the ICD, not NCD, the ICD, the International Classification of Diseases. We'll review HCPCS, those Healthcare Common Procedure Coding Systems, and we'll talk about CPT. Again, HCPCS is actually divided into CPT and Level 2. We'll get into that in a little bit. These codes are used in every single healthcare setting that you can think of. Inpatient, outpatient, facility, physician settings as necessary. Other settings as well, like perhaps like psych hospitals, other behavioral health clinics. So ICD, International Classification of Diseases. So the history of them. So here on the slide, it's saying the origins of that ICD can be traced back to the 17th century. It actually can be traced back even farther than that. In the 15th and 16th centuries, European societies, their boards of health, needed a way of classifying, again, how their population was dying, similar to here in the 17th century in London, but back in the 15th and 16th century, again, kind of the same thing. They needed to classify a way of identifying how their population was dying. Was it plague? Was it, um, all sorts of different ways that you could possibly die back in the 15th and 16th century. So this data set did evolve into that classification of the causes of death, and then it actually became the International Classification of Diseases back in like the 1900s. So 1898, 1900 was when it was adopted for use actually worldwide, not necessarily just in the United States. That's why it's called International Classification of Diseases. And the intent was to revise this ICD every 10 years. So back in 1900, when it first was adopted, 1898, 1900, right around there, that was its first revision. In 1975, that ninth revision was adopted for use as the ICD-9 code set. So you can see how it kind of evolved, every 10 years. So ICD-9 was set to expire on October 1st, 2015. So the thing is, as you can see here, there's a bit of a discrepancy between, 1975 and 2015. That's not a 10-year span. That's about a 30-year span. No, actually, that's a 40-year span. So what happened? Why did it take so long to update from 9 to 10? So ICD-9 was a pretty limited code set. It couldn't be expanded. And ICD-10, which was adopted, implemented and adopted by the World Health Organization, had ways of expanding the codes. When we get into ICD-10-CM, I'll show you how codes can be modified and expanded. ICD-9 pretty limited. At its last iteration, there were about between 14 and 15,000 codes. When ICD-10 first dropped in October 1st, 2015, there were at least 71,000 codes. It multiplied exponentially because it was much more granular. It was able to identify what side of the body you were injured. Was it your right arm? Was it your left arm? It gave a little bit more specificity to other diseases such as diabetes and other types of musculoskeletal conditions, skin, subcutaneous tissue conditions. It just was able to identify on a much more granular level. But 2015 it wasn't just the ICD-10-CM code set that was implemented. ICD-10 PCS was also implemented. And what that did is it identified a brand new procedural coding system. Now that one, the procedural coding system, is specific to the United States. ICD-10-CM is also specific to the United States. Yes, it is an international classification of diseases, but CM is that indicator that indicates that that is specific to the United States. ICD-CA is the set that they use in Canada. ICD-10-NL is the set that they use in the Netherlands. So ours is a little different because our code sets, our diagnosis code set, procedural coding system, these are linked to payment mechanisms. Other countries where they have like universal health care or socialized medicine, their data is not necessarily linked to a reimbursement schema. More information here regarding ICD-10-CM. So again, ICD-10, those diagnosis codes that identify why they went to go see the provider. What was going on with that patient? What was wrong with that patient? What was the disease? Those are going to be your ICD-10-CM codes. ICD-10 PCS, those are the codes that are used to report procedures in an inpatient facility setting. So we will talk more about that. That's going to be coming up in later modules when we get into more detail regarding inpatient facility coding. PCS are those codes that identify those procedures performed, like say you're hospitalized for a heart attack and you have a bypass procedure. That would be identified with that PCS code. So you've got separate books for each of these. Don't worry, you do not need to purchase these books for this class. In fact, when we get into the modules where we are discussing specifically these code sets, I will show you where on the CMS website you can actually download this data for free. Okay, so a little bit more here about ICD-10-CM, 3 to 7 characters long. That's how long these codes can be, 3 to 7 characters. And they use a mixture of alpha characters and numeric characters. And again, they identify what was going on with that patient. Why did they have to go to the doctor that day? A couple examples here on the slide. R51 is the code for a headache. All right, that's a 3-character code, starts with the letter R, and then 51, that identifies headache. And this other example here, so we've got S22.43XA, that's a big code. That's a 7-character code that's identifying multiple fractures of the ribs, bilateral, meaning both sides. So again, that was one of the reasons why we needed to expand to ICD-10-CM. We needed that specificity identified in that code. How many ribs did they fracture? A lot, multiple. What side of the body? Both sides. Is this the first time that they're being seen for that? Yes, it is. Was this an open fracture? Did the bones poke out of the body, or was this a closed fracture? They remained underneath the skin. That's all identified with that 7-character code. Those PCS codes, they're also 7 characters long, alphanumeric, a mix of both numbers and letters used to report a procedure performed in an inpatient facility setting. You only use these for facility billing. You don't use these for professional billing. And we'll get into a little bit more detail about that because you will use professional billing codes to identify the provider that did this procedure, but the facility is going to identify this procedure because they're getting reimbursed for everything else besides just the physician's work. They're going to get reimbursed for the use of the OR room, for supplies, for any nursing care, for everything else that is needed for this patient that comes in for this procedure. 7 characters long, so 090K0ZZ. There's so much information packed into that. Each one of those characters identifies one particular thing about this procedure, and we'll get into a lot more detail about that when we discuss our PCS and inpatient codes coming up in, I think we're going to do that in Module 6. Okay, ICD-9, just kind of this is just a little aside note here. I really don't think any systems are still using ICD-9 codes. You may see this perhaps in a system that has a crosswalk. So they may still have ICD-9 codes identified in the system, but it will crosswalk over to the corresponding ICD-10 CM code. But remember how I was talking about ICD-9 was a pretty limited code set. ICD-10, there was like 3 times the amount of codes. So it's not a one-to-one match. You may have an ICD-9 code and 4 or 5 ICD-10 CM codes that describe pretty much the same condition, but ICD-10 CM much more specificity. So I don't know whether or not you would ever run into an ICD-9 code in your daily coding or other HIM daily routine. ICD-11. So this is something that definitely strikes a little bit of fear into me. Yes, we're going to be updating to ICD-11. I seriously doubt it's going to happen within that 10-year time frame. Remember how I was mentioning that that the ICD system is supposed to be revised every 10 years. So that means we should be revising by 2025. Well, we're already in 2021, and I don't think we're going to be seeing this, at least in the United States, by 2025. The new version of it was released on June 18th, 2018. So there is a version of ICD-11 on the WHO website. It is a preliminary version. It was officially presented at the World Health Assembly in May 2019 and will be used as the official reporting system by member states beginning January 1st, 2022. The United States is not one of them. Member states are other countries. Other countries may be adopting this. We'll see. I wouldn't be surprised if the pandemic kind of set everything back a little bit, but we're not going to be implementing this anytime soon. Let's talk about HCPCS, or Healthcare Common Procedure Coding System. So this was implemented in the early 1980s by CMS, but at that time they were not called CMS. They used to be called the Healthcare Financing Administration, HCFA. HCFA. They were actually called that until June of 2001. And that's what that H used to stand for. It used to stand for HCFA, Common Procedure Coding System, but they've changed it now to Healthcare Common Procedure Coding System. That's just a little aside, nothing you're going to be quizzed on. But I like to find out, and I like to kind of dive into the history of these code sets and try to figure out how did they get so complicated and where are we now? So this here, the standardization in medical reporting wasn't achieved back in the early 80s. In the subsequent decade, more than 120 different coding systems came into play, which caused so many variations in payer guidelines and claim forms. So that's when CMS, or HCFA at the time, they intervened and said, you know what, hey, we need to make a standardized code set here. HCPCS codes implemented in the early 80s to identify services, procedures, services, products, supplies that were not included in the CPT code set. So this kind of describes how the level 2 codes came to be. So when I talk about HCPCS, there are 2 levels. You have your level 1 and your level 2. So here, this is just an explanation of what they are. Level 1 codes were actually CPT. HCPCS Level 1 codes are the current procedural terminology code set, which identify procedures, treatments, services provided. Oftentimes, they are also described as professional codes. The Level 2 codes are again identify lots of different things: ambulance services, supply codes like drug codes, not the NDC codes, but for, like, vaccines or chemotherapy. Also other supplies such as casts, splints, um, wheelchairs, uh, other types of braces, orthotics, prosthetics. All of those are identified with those Level 2 codes. So again, kind of an illustration of that previous slide: Level 1, Level 2. HCPCS codes, Level 1 is going to be CPT. So we don't have to say HCPCS Level 1. We can just say CPT. That's just what, we'll understand what we're talking about. Level 2 are the HCPCS codes. Oftentimes they're referred to as HCPCS 2s. Or also, if I say HCPCS, that usually means I'm referring to those Level 2 codes. So kind of getting to know the language, the lingo of these code sets. CPT identifies all of those professional services. HCPCS are going to be identifying other things such as the supply. Okay. And again, Level 2, again, we'll just refer to that as HCPCS from here on out. They are 5-character alphanumeric codes. 5 characters. Usually they start with, actually they always start with a letter and then 4 numbers. So you can see here the example on the slide: A4616 for tubing, oxygen per foot. This would be for like wound care, for like oxygenated wound care of a wound on a foot. Also, you're going to see some codes in these HCPCS that identify services only for Medicare beneficiaries. You'll also see some codes that are specifically designated for state Medicaid agencies. And we'll go over what those look like when we get into that module. Level 1, so we're kind of going backwards here. Level 1, these are going to be our CPT codes. They're 5-character codes. These are they are identified with 5 numeric characters. There are some categories within CPT that may have an alpha character in it. We'll get into that when we get into more detail of this code set. Now, these are developed, maintained, and copyrighted by the American Medical Association. They definitely hold on to these codes very tightly. This is not a code set where you can go to the AMA website and download a PDF copy of the book. No, you do have to purchase it. So again, don't worry about it. You don't have to purchase this book for this class, but I won't be able to take you to the AMA website and show you how to get the book for free. Nope, you do have to pay for it. But we'll still learn a lot about this code set in this class. So here's an example of, on the slide, of a particular procedure. So 24500, closed treatment of a humeral shaft fracture without manipulation. So that's basically taking care of a broken arm. The humerus is going to be the upper, the bone in the upper portion of the arm. Okay. So here, again, just kind of a chart talking about those 4 code sets. ICD-10-CM. Who's using these? These are reported by facilities and professionals. So basically, your hospitals are going to be reporting these. Your doctors are going to be reporting these. Identify the medical necessity. So this patient had acute tonsillitis and had to go see the doctor for it. So whatever procedures that the doctor performed, the ICD-10-CM code identifies the reason why. ICD-10 PCS Those are going to be your inpatient facility procedure codes. The slide does say outpatient. I'm not aware of any facility that uses these to report outpatient procedures. Oftentimes they will use CPT codes for that. But 7-character codes. So here's another example on the slide here. 0BD N0ZX is going to be for an extraction of the right pleura, open approach diagnostic. And when we get to our module, we'll go into the details of what each character identifies. CPT, professional outpatient facility reporting. So your providers who are doing your annual exams, the provider that is doing that closed manipulation of that humeral shaft fracture, they're going to be using these CPT codes. So reporting for these procedures. HCPCS, remember, we're going to just call those HCPCS codes, but those are those level 2 codes that identify this example here on the slide is going to be for that heparin injection. It identifies that supply. Okay, using the codes together. So I broke my arm, which is the diagnosis, and I got a splint applied. That's going to be the procedure. ICD-10-CM identifies the medical necessity, the diagnosis. Broken arm, that's the diagnosis. Now here they're saying that they must be used in conjunction with CPT, HCPCS, and or PCS codes. They're talking about linking these together. So let's get into a little bit more of an understanding about this. So again, I broke my arm. That's the fracture diagnosis. The procedure is that fracture care, whatever it is, putting on a splint, manipulating that bone back into place. But before we do that, let's talk a little bit about modifiers. Now, going to be totally honest, modifiers are my least favorite thing about CPT and HCPCS codes. They can be very confusing. After you've got your diagnosis assigned, your procedure code assigned, you got to look at the modifiers. Is there something about that record, something about that encounter that indicates that I'm going to have to identify something that was a little different about that? So, did they discontinue that procedure? So see here on the slide, modifier 53 indicates a discontinued procedure. The provider had to stop the procedure for whatever reason. Perhaps there was maybe an anesthesia reaction or something happened. They had to stop that procedure. Lots of CPT modifiers. We'll go over those within the chapter for CPT that identify lots of different things. Was there a decision for surgery during that examination? I went to the doctor examined me and said, you know what, hey, we're going to have to do surgery. So there's a modifier that indicates that. There's a modifier that indicates multiple procedures done during the same operative session. There's a modifier that identifies, oh, this was on one side of the body or the other side of the body. Same thing with the HCPCS modifiers. There are lots of different modifiers within the HCPCS manual. These are going to be alphanumeric. CPT modifiers are always numeric. HCPCS modifiers can be alphanumeric, and they can identify lots of different things. Like this was a bandage for the third toe. This was new equipment. This was a procedure that was performed by the primary physician. So lots of different indicators that these modifiers will point to. Now, who is responsible for updating the code sets? So we'll get into more detail about this in the upcoming slides and also the upcoming modules, but they are updated at least annually. Your ICD-10-CM and PCS books, they come out October 1st of each year. It is a year-long process, though, in order to get there. They actually start that process way back in like February and March. The the ICD-10-CM maintenance committee and the committees that are responsible for maintaining these code sets, they meet to discuss with stakeholders, hey, what needs to be identified with a code. So to say that they get updated at October 1st of each year, for the most part, is true. However, when COVID came out, when the pandemic hit, we needed a new code to identify COVID-19, and we could not wait until October because the pandemic hit early in 2020. April 1st was when the COVID code, which is U07.1, came out. So that actually was updated in April. There are instances, it doesn't happen very often, but they may be updating codes biannually rather than just once a year. CPT, the procedure codes are updated January 1st of each year. And again, it's a year-long process. The American Medical Association has a CPT editorial board that meets throughout the year to discuss revisions, additions, deletions of CPT codes. But the book is released January 1st of each year. Now, HCPCS, they happen on a quarterly basis, but books only come out once a year. However, you can go onto the CMS website. They are responsible for maintaining this code set, and you can see which ones are being updated. Certain code sets are updated on one schedule, like drugs would be updated on this schedule. Other code sets would be updated on a different schedule. All right, and again, just kind of a little visual here of how these codes are updated. All right, so codes are not just used in that medical record. They can be used, the data that these codes produce can be used in all sorts of instances. Departments of health use this for tracking of disease, especially now with the pandemic. It's been incredibly vital to have these codes identify where the disease is popping up, who's getting tested for them. The vaccine codes are coming out, so it's incredibly important to get this data. Internal tracking within a facility or within an office to see, which patients have which diagnoses. We talked a little bit about this in our previous couple of chapters when we were talking about risk adjustment, those hierarchical condition category codes. Diagnosis codes are used for that. Also for performance measurement, quality improvements, research funding. Facilities can use this to see which departments are utilizing which services, which supplies, also to see, how sick is our population, how sick are our patients that are coming in, and what are their outcomes. Okay, so putting this together, and this is a pretty simplified discussion of coding. So 2 parts to every claim. You're going to have your diagnosis codes and your procedure codes used together to talk about what happened during that encounter for that patient. Again, diagnosis codes identify why that procedure was performed. Why did this patient have to have that cast put on their arm? Well, because they broke it. Procedure codes identify what that provider did to treat that diagnosis. Okay, again, what the doctor did, that's the procedure. Or perhaps this was the evaluation and management. So a little bit of a differentiation there. A procedure, when I talk about procedures, I'm talking about like surgeries or a test or something like that. That to me is a procedure. Evaluation and management, that's a service. Those are going to be your visits. Why did the doctor do it? Well, I came in complaining of a headache, so the provider did an exam. They wanted to figure out what was causing that headache. Okay, so example here, we're using fractures quite a bit as examples. So patient presents at the clinic with an injury to the wrist after they fell. The orthopedist, they did that x-ray, identified that fracture, and then they did that closed manipulation of that fracture. Closed manipulation meaning they didn't have to cut into the patient in order to set that bone. They were able to kind of manipulate it back in place, and they put a cast on that wrist. So what did the doctor do? They performed an x-ray and then performed that closed manipulation of that fracture. We actually kind of have two procedures there, depending on how the billing is set up for that particular facility. They may bill for both the x-ray and the procedure. Perhaps they sent the patient down the hall to the diagnostic, the x-ray the x-ray department, the radiology department shot that x-ray, sent the patient back, provider read the x-ray. Oh, hey, looks like you have a broken wrist, and we're going to reduce that fracture and put that cast on it. Why do they do it? Because I broke my wrist, the fractured right radius. So when you think about a broken wrist, you're not actually breaking a joint, you're breaking the bone that's in that joint. And so that would be probably the distal portion of that radius, meaning they fractured. This is a right, so on your right arm, that distal portion of that radius, that's going to be the portion that's furthest away from your core. So that bottom portion of that radius, which is part of your wrist. Okay. So again, depending on how the billing is set up, provider is going to bill for that x-ray and for manipulating that bone back into place. And those are going to be identified with CPT codes. The diagnosis is identified with that ICD-10-CM code. Linkage here. Linking the diagnosis and the procedure. The diagnosis identifies the medical necessity for that procedure. All right, linking them identifies again why they were there, why they had that procedure performed. So take a look at this other example here. So I go into the provider, I've got a really itchy sore throat. I also have anxiety. The provider performs that strep throat swab to check for streptococcal pharyngitis. It's a positive result. So I've got strep throat. And they also perform that E&M, an office evaluation and management visit. Prescribes the patient with a prescription for anti-anxiety medication. Now, coding linkage here. This, again, is just a really simplified version because it may not necessarily be a one-to-one ratio, but let's just go with this. So that CPT code for the strep throat swab, 87880, all right, they did it because they suspected that I had strep throat, and that's going to be ICD-10-CM code J02.0. All right, that E&M code, which is 99213, it's going to be linked to that anxiety, F41.9. All right, so it links these procedures with each diagnosis. And again, kind of a breakdown here. Strep throat swab, why? Well, because I have strep throat. They wanted to see whether or not this was positive. So they swab my throat, and then they come to the conclusion that indeed I've got streptococcal pharyngitis, which is identified with J02.0. And that E&M, and again, like I said, this is a really simplified version because you might be thinking, well, wait a minute, they went into the doctor because their throat hurt and they had anxiety. So kind of E&M kind of would point to both of these diagnoses. But again, just for the simplification of this, let's just go with that. Okay, so those codes get linked together on that CMS 1500 form in box 24E. The letter listed in that box should correspond to the code which is linked. So here's an example of that. All right, so office evaluation 99213, they were there to have that swimmer's ear looked at. So you can see here on the slide here that diagnosis pointers. So here's your procedure code. The diagnosis pointer here is identifying the H60.332. Cryosurgery, which is the freezing of tissue, they did that to remove this wart. So the cryosurgery is going to be linked to this procedure code. Cryosurgery obviously would not be linked to swimmer's ear. The cryosurgery is linked to removing that wart. Okay. Coding guidelines. We'll get into a lot more detail about this in upcoming modules. Each code set has their guidelines, and they are extremely important to understand, because if you're not following your coding guidelines when assigning ICD-10-CM codes, PCS codes, CPT, could definitely run into some problems, some reimbursement issues. And I can talk all about that because that's one of the things that I do at my job. I am looking through submitted claims to Washington State Healthcare Authority to see whether or not they are following coding guidelines. So they are those rules that specify which codes to use, how to sequence them, modifiers, how combinations of codes work together. Another thing, extremely important, documentation. If it's not documented, it didn't happen. If the provider did that cryosurgery to freeze off that wart, but they didn't document it, then it didn't happen and they don't get reimbursed for it. It's extremely important. For those working who are looking into a career in the HIM industry, in the HIM field, this is actually one of the really important kind of subsets of coding, clinical documentation improvement. There are professionals that are clinical documentation improvement specialists that work with providers to make sure that they are documenting correctly everything that they did during that encounter, because if they don't, they're not getting reimbursed for it. If they're not documenting it correctly, they may not get full reimbursement for it. So again, if it's not documented, it didn't happen. Okay. So those CDI specialists or other HIM specialists, coders, will be working with providers, can work with providers to make sure that that documentation is complete, detailed, legible. You know, it's not used very often these days. Most records are electronic format, so things are typed out. However, I do see in my line of work, when I'm reviewing some records, I do see a hybrid. I do see a combination of dictated and handwritten notes. So the documentation does need to identify the patient, and that documentation format really does depend on the facility. Okay, that brings us to the end of our second module discussion for coding basics, and I will see you all next week.